between the anterior and posterior branch of the secondary ramus. That's all the difference is. And so we tend to get pain in the hip where? Locally in the front of the hip, a deep groin ache. And then, if it spreads, it tends to spread down the inside of the leg and perhaps even down as far as the foot. And the hip joint is a joint that refers pain. Whereas, for example, the knee joint tends to be much more local, or if there is a spread, it still seems to stay in the region of the knee. But very often people have aching, as we know, with osteoarthritis, when it's in a flared up pattern, tend to have pain down the inside of the leg. So when we're looking at pain in this area, there's a lot of dermatomes, which means there's a lot of tissues that can derive this pain, and sometimes just a bit of an analysis of where the pain is focuses at least on a group of tissues that we can then perhaps put some specific testing on. Okay, next question. In terms of the scan, what have we done that indicates the hip joint? We can think about the pain pattern, of course, and pain down here tends not to come from the spine, doesn't it? Because it can do, but L2-3 or L1-2 isn't a really common spinal area. Now, in the case of the guy I was telling you about, he was about 41 or 42. So, and this was definitely not deep pain here, but definitely testicular pain. But he's not falling into a pattern that I would think in a sort of mature adult that should be giving hip joint arising pain. So we're going to look at that little thing that we saw yesterday in terms of what can happen at certain ages, fit it in with the pain pattern when we're kind of just thinking about what to examine, and asking ourselves in the scan what showed up that the hip joint should be looked at in specific terms. Those are the things we should do. So in the scan, what did we find that would suggest hip joint? Okay, there could be a positive Faber's test, right? That is one of our kind of eliminating tests, because it's fairly thorough as far as the hip is concerned. We know that it was essentially a sacroiliac joint stress test, and when we go to the tables, we'll have a look at trying to differentiate this between sacroiliac joint and hip joint. And tomorrow, there's one or two other little tests like this in terms of forward bend and lateral bend, where we may be able to sort of focus on a particular tissue. Evianth is working on this at the moment as a kind of a new product, and I'll sort of show you what it is, and you can kind of work on it yourselves, because you can become the new Evianths. Okay? Now, anything else in the scan that we may have done that indicates the hip? The squat test, which is a very quick lower limb evaluation. And they've gone down and something kind of couldn't get right the way down. Where does that feel? No, it feels up here. So this makes this test a little bit more important when we're just doing through the scan. So we can think to ourselves, right, the hip needs to be evaluated very carefully. And if it fits in with an age group, and if it fits in with a spread, it tends to focus us a little bit. Now, I think sometimes, you know, we get so caught up in biomechanical analysis and biomechanical models that sometimes we forget the kind of orthopedic medical model. And there are problems with all of the models, so if we kind of link them together the best we can, perhaps we can eliminate some of these difficulties. Perhaps we can compound them too by adding them together, but hopefully we can see the weaknesses of one system and the strengths of another and try and kind of marry them together a little bit better. Now, if we have a look at a sort of an evaluation chart, I hope that this is a little bit small, and I probably should have done it in two parts and enlarged it a bit. But I will read it and we can kind of go through it. This is taken from Reed's book. And it shows the thoroughness of an orthopedist examining that is totally aware of manual therapy. So, in standing, we're going to have focused on the hip, and now we're going back to the hip to try and pick up parts of the hip joint here. So, in our observation, we're looking at posture, alignment, and of course, visible muscle wasting. We'll look for any pelvic obliquity, because of course alterations in the pelvis are going to make a difference to how we can enact some of these muscle actions. And it's what we suggested yesterday. You know, where do we start? Do we start by trying to correct muscle? Do we start by trying to kind of alter bases over which it works? I guess it depends, as we said, perhaps on our original orientation. Now then, he's got some weight-bearing tests here. Trendelenburg. I'll just go over the Trendelenburg with you. Just before I came, I found an article, and I was looking at this article and thought, why would in a modern book anybody want to write much about the Trendelenburg test? This was like 5 pages long. And it was written because this fellow had said that he'd asked 6 of his orthopedic colleagues about the Trendelenburg. All of them did it, and all of them did it in a different way, and all of them concentrated on different things. So he says, here's one of the standard tests that everybody says they do, everybody accepts it's a very important test, and nobody does it the same way. So there's a real problem of communication. You do it a slightly different way and look for different things, and your colleague, he must have been having a bad day here, because he's looking for different things. So this is one of these standard tests. And I think, was it you, Jim, was saying yesterday, you know, we sort of are always on the ball for defending what we do. Many of these other groups sort of are making these challenges. Really, defending what they do is very difficult also. That doesn't alter our responsibility to defend what we do for ourselves. That's for certain. So, we've got some weight-bearing tests. The Trendelenburg test, the forward flexion test, which grossly, of course, is going to look for hip joint movement and also length of the hamstrings and important things like this. The ability to squat and duck waddle. Specific palpation of hernia sites. This would be in terms of the femoral hernias and also the inguinal hernias. Now then, as far as sitting is concerned, he's got some very important things here. The ability to cross the leg over the opposite thigh, which is kind of a gross way of doing the Faber test. Hip flexor and knee strength, done in sitting, which we've probably done in our scan anyway, so this might not need to be repeated. Reflexes if indicated. We've done that, but we know the answer to these sorts of things. And the tripod sign. This is going into extension of the knee. Does the patient lean back to eliminate the stresses on the sciatic nerve? The way that we would look at someone who is, in fact, giving us the wrong information. I had a really interesting fellow. I quite like him, but I've seen him for about 18 months off and on, and I've seen him from the time when he started treatment, where I thought that he'd got a whole lot of inconsistent findings. So I was really thinking that there was a lot of this back problem with sciatic reference, what Stephanie Saunders calls supratentorial bursitis. Okay? And then we lost track of him because he didn't help him. Next time I see him, he's walking on 2 canes, walking very gingerly because he'd had surgery now. And I think to myself, geez, why would anybody look at these inconsistent signs and do surgery? So he comes in and he's sort of telling me, oh, doctor, I'm really a lot worse now. So I sort of sat him down and I looked at all the signs again. Straight leg raising, about this far off the bed. Tried to bend his knee, couldn't stand it, looks like a sign of the buttock. Ask him to just sit up so I can look at his knee, and he sits up at 90 degrees, you know. So there were all these inconsistencies. So when I spoke to the orthopedist about it, I said, you know, I don't think we're going to get very far, and he said, I agree. And I said, there's all these inconsistent signs. And I said, you know that his life has been made quite interesting by the fact that he's got a nurse comes in and baths him 3 times a week. He's got somebody who comes in on a 3 times a week and does all his house out. And the neighbors run him around all over the place. And so the orthopedist then said, yeah, I know. He said, but did he tell you about his 2 brothers that were killed by the Ayatollah? And I'm really feeling guilty now about this fellow. But he's a really nice guy. So last time I sort of wrote these reports after the compensation, said there are very inconsistent findings, and I think that the WCB should review where he's at. And then I got this phone call from this therapist who said, I've been asked to review this fellow. What did you find? And I gave all my things, and she said, thanks, I'll just say we should put him in the pain clinic. And so here's a sort of an interesting thing about inconsistencies. So in this particular case of the tripod sign, we should not produce very much problem as far as the hip joint is concerned unless the sciatic nerve is particularly irritable, and then they will lean back, which means it's probably being referred into there and somewhere else needs to be evaluated. Now, I think what might be the case here is that this is presupposing that the scan hasn't been done. And this is probably quite likely if you go and see an orthopedist in a sports medicine clinic, that fundamentally they probably, Reed would do it because he's sort of used to thinking this way, and of course he came from us. But other ones tend to sort of focus perhaps a little bit more on the site where the patient thinks the injury is. And so these things would pick up if you need to go back and do much more of a spinal evaluation. But if we've done them, there wouldn't need to be coming in this sort of thing here. And then we get the patient into supine, and we go over just the typical things that we do: active, passive, and resisted movements. Now then, what are we sort of thinking about in terms of passive movements? These are not glides. We're not talking about accessory movements. We're simply talking about the normal physiological motions. And probably the one that is the most important in my estimation, which seems to sort of focus on the hip more than most of the others, is to take the hip to 90 degrees and do a medial and lateral rotation motion. This seems to be one of the simplest tests that we can do, which tends to implicate the hip joint. So he's got all of his stuff here: active, passive, isometric, other passive movements as indicated, such as abduction, extension, flexion, and so on. And then a whole group of special tests, and we're into joint play. What are the real joint play movements that we can feel in the hip? Probably distraction. And this is, generally speaking, done more efficiently, funnily enough, not by an accurate distraction, which would be parallel to the neck of the femur, coming out that way, but by doing a caudal glide. This produces, generally speaking, the biggest separation in the joint on most of these videos, x-ray videos that have been done, the downward move. So we can do a little motion to see what happens. But generally speaking, of course, we do a lateral distraction as well. Feeling posterior and anterior movements, looking at a male surface, much, much more difficult to do through the hip joint, I must say. Now then, very important if we can do it, and if in the presence of all this movement loss is not very marked, we can try and do the quadrant tests. And the quadrants that are probably the most important will be coming up into a flexion adduction quadrant, and probably a flexion abduction external rotation quadrant. So we'll be flexion adduction internal rotation, flexion abduction external rotation quadrant. Then we've got other things that we can do around here if we suspect, because the joint range is not bad when we try this distraction, and we've got restriction of motion. Then what we should try and do is to do perhaps some of the length tests for muscle. Now, other things here is to perhaps put in the Faber at this stage and try and... Oh, you didn't know we were starting at 8 today, Ken. Sorry about that. Sorry about that. Okay, the Faber test here, and we'll try and do that differential thing at the Faber at this time. Leg length measurements. There are 2 ways of, or 3 ways of doing leg length measurements. And then there's the super accurate way of doing x-rays and all this kind of stuff that are all related to measurements in terms of how the beam hits the body. Most of the patients I see that would never think of doing an x-ray for leg length, I must say. Our system can't afford that. Okay, so it probably wouldn't be done. So where are we stuck with this? Well, I think there are 3 ways we can do this. A study that was done and reported in your journal, the Journal of Physical Therapy in the United States here, did an evaluation of points that are normally taken, such as coming from the anterior superior iliac spine to the medial malleolus, from the anterior superior iliac spine to the lateral malleolus, and found that on the whole, the lateral measurement was far more accurate than the medial measurement. But we're only accurate to about possibly half a centimeter or something like that. We're not talking about accuracy to like a couple of millimeters or anything like that. That's one test. Another one that we can look at is one that is reasonably good, which is the one where we look at the bent hip and knee, and we try to evaluate whether we have got a short femur or whether we have got a short tibia in terms of this total leg length problem. And so this is something that we can run through with each other to look and see what's actually happening here in terms of the difference between this or the leg forward but down from front to back, indicating more the tibia rather than the femur. So these are measurements that we can do in this position and get some idea of where the discrepancy exists. I mean, it doesn't make any difference to us. Perhaps we're going to have to use heel lift therapy, obviously, but perhaps for an orthopedist who might think about lengthening a very short one, this would be much more important. And of course, then they would go on to having a particular sort of points x-rayed to look at the exact length. The other thing to think about is in apparent leg length problems where we've got a flexion contracture in the hip. And what we're going to do there to take in this a little bit more, particularly if we haven't actually measured from the anterior superior spine, but we've measured from the upper part of the trochanter and going down, is to measure from the umbilicus. And this will take in sort of a leg length if one leg is externally rotated and shortened in the sort of typical capsular pattern. Okay, then we sort of have apparent shortness in the leg length. So these are 3 ways of doing it. Looking at that, going down from either the lateral part of the trochanter or the anterior superior iliac spine to the lateral malleolus, or coming across from the umbilicus to the lateral malleolus. These are all ways of looking at problems of leg length. And if we're talking about compensation in terms of compensatory changes, then these things perhaps we should be thinking about as part of this retraining normality and reducing disability in people. In prone, we can do all of these tests again if we found for some reason that these are haven't been done, or it's not been convenient to do them in this position, or for some other reason. And of course we can get hip extension. How much are we measuring as normal extension in the hip? So we're going from here, which sometimes is called hyperextension, but just from here to there. It's a very small amount. It's about 10 degrees. A lot of the other stuff is coming from ilial movement and from extension of the lumbar spine. So when we're testing this, we should actually push on the ilia to stop it going into anterior rotation. So we should put some bracing against the back of the ischial tuberosity, so that when we lift the leg, it's at least only in the hip and not bringing in everything else. So this is kind of an important point. And we can look at specific areas now, can't we? Ely's test. What's Ely's test? We tend not to use these names, but there are one or two sort of standard names like Lesage and Ely and Obers and these people that tend to get used in standard orthopedic stuff here. Chiropractors are very, very keen on names. It's kind of interesting reading their articles. You've kind of got to go and almost look up a glossary of the names because you forget what the names are, and it shows you the inadequacies of this. Ely's test is to test the length of rectus, and how they do it is to just lay the patient prone, flex the knee up against the posterior part of the thigh and see if there is any flexion of the hip. That is Ely's test. You might have other ways of testing the rectus, that's fine. But Ely's test as it stands is to just take the heel, try and push it against the buttock and have a look and see whether it has to be done with some flexion of the hip, in which case the buttock will rise up. Now then, in all of these positions of supine and prone, if it's convenient, although I think it's probably better to do it at the end when you've made up your mind more or less what to concentrate on, but we can look at specific areas for palpation, but we'll leave that right down to the bottom here. And lastly, in side lying, well, this brings us into being able to do resisted abduction and adduction, which might be important if the Trendelenburg was in fact inadequate up here, to just confirm what's happening there. Ober's test for ITT restriction and tensor fascia lata restriction. How do you do that?
Bring the thigh into extension.
And
Drop it into adduction.
And how far should it go on a normal person?
Should go all the way to the table.
Probably not.
Just below.
About it should get level with the inside of the opposite leg is a reasonable thing. And what we should try and do on this to some extent is to stabilize once again the iliac crest, so we just don't produce a side flexion of the spine. So we should be looking for those particular points. So we're going to sort of abduct the leg and extend it so that the iliotibial tract is over the trochanter, and then we just sort of drop it down. And then we sort of come up with what our normal limits are. Finish off with sensory testing, which of course we've done, and then into palpation. Now then, there's one or two other things I think we should put on here which we would be concerned with. One of them is the sign of the buttock. Anybody like to tell me what the sign of the buttock is, and then what its significance is? Yes, Kathy.
Hip flexion is limited regardless of whether the knee is in the same amount. It's limited regardless of whether the knee is straight or bent.
Yes. And?
Can be indicative of...
No, we haven't finished yet.
Oh.
That's true, but there's one other thing. In the absence of a capsular pattern of the hip. So that's it. We've sort of done the capsular pattern, then it's equal restriction of flexion of the hip with the knee extended or the knee flexed. We all know it should get better if it's sciatic nerve insufficiency, hamstring insufficiency, or whatever. Now then, we've kind of added quite a lot to this test. But that was the sign of the buttock as far as Cyriax. And I'll ask Anne this afternoon what he said it was, whether that was it as far as I was concerned. Equal restriction of the hip and the knee, or of the hip, whether the knee's flexed or extended, and the absence of a capsular pattern. It'd have to be a fairly severe capsular pattern, of course, to restrict it. Now then, other things that we've kind of put in because of the seriousness of the problem that you could probably guess at. It'd probably be an empty end feel because of the reactivity of this thing. When we palpate, we might palpate a number of things. The chances are, because of the seriousness of the pathology with a sign of the buttock, that we're going to have gross weakness, either of the abductors and the extensors, particularly gluteus maximus. So that would go automatically with it. Now then, Kathy, you were going to tell us, what are the causes of this thing?
Osteorectal abscess.
Yes?
Sacrum.
Yep.
Osteomyelitis of the femur. Severe bursitis, I believe it was, or severe trauma to the gluteus maximus. He had severe trauma to that. Tumor, metastatic invasion.
Mm-hmm. So all pretty bad. So we've got a number of fractures, we've got a number of sort of metastases, perhaps some primary lesions and this kind of thing, or infections. So we're going to sort of look at the buttock itself, and we might see that it is very flaccid and that the strength is absent. On the other hand, we might see that it is enlarged if it was a big mass. Anyway, this is something to send the patient back. Here's the list of Cyriax's things, which were pretty well the same as Kathy came up with there, of course. Osteomyelitis of the upper femur, septic sacroiliac arthritis. So we're really looking at serious things here. An infected or an ischiorectal abscess, septic bursitis rather than just a severe traumatic bursitis, rheumatic fever with bursitis, neoplasm of the upper femur, iliac neoplasm, fractured sacrum. Don't lend themselves well to manual therapy intervention. So obviously these need to be referred back. And this is a very important aspect of what we look at when we look at the hip. Now, just for the good of your soul, and to concentrate on one or two of those things, I'd like you to sort of go to the beds, and then what I'd like to do at the end then is to just sort of do some palpation around a number of structures. So, ignoring that group, of course, because apart from perhaps feeling the buttock and seeing if we could identify a mass, or seeing if it is very, very locally sensitive, I've only ever seen a couple of cases, I must say, of osteomyelitis, and also a couple of cases that I saw of bone cancer that I sent back and that was then diagnosed. And the characteristic of these, I always remember, was incredible sensitivity of the bone on light pressure. So just pressing very lightly for the osteomyelitis, which was actually in the lower third of the femur, was exquisitely tender for this person as compared with the other side. They were sent in for an iliotibial tract thing or something like this, but it was exquisitely tender. So we had that sort of checked out. The osteomyelitis I saw was of the lower femur. The neoplasm that I saw was in the upper humerus, and it was exactly the same thing. It was totally intolerable